Hello, everyone, and welcome to this Diagnostic event. My name is Antonio Capecha, and I work as Lab Relation Manager at Diagnostics. The title of this today's event is Pediatric Tumors, Brain and Hematological Tumors. This is our agenda of today. I will start with a brief introduction to Diagnostics as well as our precision medicine platform, the XRX. And then I leave the stage to our speaker, Professor Massimino and Professor Weinberg, for their presentation. At the end of each session, we will have a Q&A session during which you can ask any question you may have. You can share your thoughts or comments. Diagnostics is a consulting and data analysis company specialized in precision medicine. We are committed to a goal that can be summarized in our motto, better testing, better treatment. We are striving for a future where all patients can receive appropriate treatment as soon as possible. We believe that labs need to be involved earlier in the precision medicine decision-making process. We are working on many different precision medicine drugs brought to market with the world's most prominent pharmaceutical companies. We are a global team of experts spread over 53 different countries. With this in mind, we have built the XRX, a platform conceived as a digital gateway that provides a space for all precision medicine stakeholders to collaborate with one another, as well as take advantages of our data insights. Laboratories, pharmaceutical companies, and diagnostic companies can all find benefits from being registered users on the XRX. And we expect this collaboration to have a positive impact in patients. We'll build the XRX, the diagnostic network, to place laboratories at the center of the precision medicine ecosystem. Some of the services that we offer to the labs through the XRX are the XRX collaborations, an opportunity for labs and other stakeholders to work together, for example, participating in ring studies or other specific scientific programs, as well as getting access to grants and sponsorships. Labs can increase their visibility to other precision medicine stakeholders, such as pharma or diagnostic companies. Access to educational resources, lab talks, webinars, biomarkers, reports, and newsletters. Access to aggregated data by participating in our data strategies. This is conceived as something that lab can benefit from, and as such membership is free of charge. If you are interested in a lab offering of the XRX and would like to know more, please reach out to us. So, before starting, I want to introduce you our speaker. We have Professor Massimino and Professor Weinberg. Professor Massimino is the Director of the Pediatric Oncology Unit at Istituto Nazionale Tumori in Milan. Her clinical research is particularly devoted to childhood brain tumors, lymphomas, and thyroid cancer. Professor Weinberg is Professor of Pathology and the Director of Fellowship Education and Hematology Laboratories at UT Southwestern Medical Center. She has served on numerous education committees, including Society of Hematopathology, USCAP, and International Clinical Cytometry Society. So, thanks for your attention, and it's time to leave the stage to Professor Massimino. I hope you'll enjoy this event. Thanks for your attention.
Good afternoon and good morning, everybody, and thank you for inviting me. My topics will be around high-grade glioma, and this is the premise of our story, that the most important solid tumors for children are brain tumors. In Italy, where I live and act as a physician, there are around 400 new cases each year. If we compare to what we will listen after my talk, so about leukemia, there are not such brilliant results as they can claim, but nevertheless, in the last 20 years, we have assisted at a reduce of mortality also for brain tumors. This means that around 60% of affected children can become adult. And if we think about the improvement, we have to speak mostly about embryonal tumors. And since 2000, there have been a great improvement, but this improvement is not to be applied, unluckily, to both low-grade and high-grade astrocytoma. There was no improvement during the last 25 years, and this is a major pain for our daily activity. So I am speaking of an unlucky disease, and in this group I will deal with high-grade gliomas. In the meantime, when we were going to prepare this talk and we were working hard to make something more for our children, there was a new classification of WHO on brain tumor that appeared 3 years ago. And this has brought some very important differences, especially for what brain tumors in children are concerned. From a purely phenotypic classification until the fourth revised classification, there was the introduction of genotypic parameters, and it is now mandatory for many of our tumors to have molecular criteria that are considered essential for diagnosis. If we see this, sorry, I would like to enlarge it, okay. If we see this cartoon, you can see that there are different tumors according to different patient age, including infant, primary school patient, and early adolescents. And looking inside the boxes with different color, you can see that there are different tumors in red that are correlated to the new differences in high-grade glioma. So the hemispheric tumor that are typical of very small children, the wild type IDH and H3, the mutated K27, the mutated G34, and here there is this K27 histone H3 mutated that are the midline one and are frequently represented in primary school age, but also in small children and older, and also in adults. So there is a very different group of tumors that are very typically characterized in this new classification. If we go to see what happens, these are also represented in different way in this picture of MRI. This is a more superficial tumor. It could be a G34 mutated tumor. This is a thalamic tumor. Could be a DMG with the mutation of H3 K27 that is typical. Again, this one. This is a posterior fossa tumor in a small child, and this is a very huge hemispheric infant tumor. So different representation are possible also to be distinguished from the point of view of imaging. And you see here the frequencies of this tumor around 10%, 10-15% in children, and a little more in adolescents. But how is to go to a diagnosis of high-grade tumor? Also, already 20 years ago, when there was, let's say, only the morphological diagnosis, Pollack said that it was very difficult to conclude a diagnosis. And for any experienced pathologist, not exactly a neuropathology, but a surgical pathology, it was a difficult diagnosis. Some years ago, we performed an analysis within Europe with different samples in different, our concordance was very low. So also experienced pathologists can make mistakes if these are mistakes, and perform different diagnoses on the same tumor. So a judgment, a final judgment, has to be done with a lot of features that the last classification has introduced as compulsory. Until 10 years ago, it was felt that the phenotypic that is identical in adults and children was the one to be considered for the diagnosis, and children and adults had the same disease. But this is in fact different also from the topographic point of view, because you see that half of the patients in childhood age, pediatric age, have tumor in brainstem, while this is very rare in adults. On the contrary, the supratentorial compartment that is very common in adults is much more rare in children. Rare for both ages are the spinal presentation. So also the topographic is different in these two different patient age. And in 2012, it was discovered from two different groups in Canada and in St. Jude Hospital that there was a typical mutation, the one that I quote also already before, that was the maybe the true pathway to give origin to pontine tumor. And this was present in nearly 80% of the IPG in children and in 22% of non-pontine glioma, exactly the type of tumor that is now classified as DMG. And this is not present, if not rare, in adults, and maybe represents the clear border between adults and childhood tumor. You can see here the IPG with this group of typical alteration, never found the IDH1 mutation that is quite more frequent in adolescents and in adults, while PDGFR amplification is present, and this is of course the marker of this tumor. If we go in older adults, we have a totally different group of genetic alteration, and in between we have this group of child with no ADH, while adolescents have sometimes ADH mutation and other alterations that are more rare and more typical of a certain group of patients and certain group of tumor. This is again represented here in the slide. There is a certain delay between what I say and what I can show. Okay, there are so many different of high-grade glioma, a awful family with this one that is 0.5% of patients in midline location and the alteration that I described you before. The second part that are the one with no alteration in histone H3 and no alteration in IDH1. And lastly, this more likely, as you can see below, the approximate median survival of small children with alteration, the mutation of RAF V6000, that is more close to the behavior of a low-grade glioma. And as I show you in the imaging, also the location in the brain are different. A midline tumor, a more cortical tumor with G34 alteration, and here again all the possible location, the more frequent location inside the brain of a child or adolescents. So when we see in our grass some flowers, we can think that are both daisies if you are not an expert in botanics. But if you look back on the seeds are very different. And on the left, these are the seeds of the daisies, but on the right, these are chrysanthemums. And this is a kind of difference that we are now compelled and able to understand when we deal with our high-grade glioma tumors. And what I want to conclude in this very first part of my talk is that these differences are crucial, and we should at least think about different therapeutic strategies. I have shown you what happened during the different classification, and now again I show you these four different diffuse tumor in children that are all grade 4 for definition, while in the adult counterpart there are still some grade 3 tumors. This is not what happened for children. Every high-grade glioma in childhood is a grade 4, so the most awful of all. This new classification has put some question to pediatric neuro-oncology as I am. You see here a lot of question mark and a lot of doubt of what we can do with new classification. And the most important is to have this group of tumor that are not called any longer just H3 K27 mutated, but altered, because they include, this group include 3 different subtypes, the most common with the mutation that I described you before, or the EGFR mutation that sometimes is accompanied by the HK27 mutation, and finally the wild type, but with a zip overexpression. These 3 subtypes have in common the loss of trimethylation, and this is possible to be seen with the immunohistochemistry. So this is the typical alteration, the mutation, the substitution of lysine with methionine, and the first site that we thought to be the only one with this mutation, that is the pons, but now we know that there are other locations like this one in basal nuclei. And in all the series, and this is the possibility to see with the immunohistochemistry the loss of methylation, but all series that have been described in a retrospectively way using this new classification, and have shown the same awful prognosis for this mutation of histone 3. This is the K27, this is the G34, and this is the last randomized trial in Europe. Again, you see the wild type tumor and the one with the mutation of the histone that go much worse. So in our present history, we have to recognize this new subtype. But the question for physician like I am is which is the standard, or if there is a standard that can be that can suit this new classification. As of now, there have been very, very few randomized trials. This one that was published a lot of years ago, for the first time showed that the addition of chemotherapy to radiation therapy could improve the prognosis of this patient. This was only partially true, because when there was the revision of the histopathological sample, as I told at the beginning, many patients that seemed to have a high-grade glioma, in fact, had a low-grade glioma. And therefore, the most important thing in the outcome of the patient was not the presence of chemotherapy in the trial, but the presence of post-surgical residue. That is still the most important prognostic factor when we group all the patients together. So it's very difficult to imagine a standard arm when you have just 10% of the patient that survive longer than 3 years. And it is also difficult to compare with historical experiences because the criteria may be different also from the, apart from the pathological and the biologic point of view, also from the imaging that you use or the technique of radiation therapy, the field and the doses that you use. But nevertheless, it is something that we have to improve in our experience. And before this effort that I will tell you later, the only randomized trial that was published and was applied also to children was the STOOP regimen that appeared to improve adult patients with high-grade glioma with the use of temozolomide together and as a maintenance therapy after radiation therapy. And so this was like a freeze of a lot of efforts in pediatric world because everybody was giving just temozolomide without trying to improve the outcome of this patient. The last randomized trial that I showed you already before was to add in this background of the use of temozolomide something new. And this something new was felt after the adult experiences to be bevacizumab. And in fact, this was a trial comparing the classical STOOP regimen, but with 12 months of temozolomide as maintenance with STOOP plus bevacizumab. Unluckily, the study was closed in 2015 without showing any superiority of the experimental arm. Therefore, we cannot count on bevacizumab as a new tool for pediatric high-grade glioma. But later on, there was another publication with a different approach with the introduction of a very old drug in our market, in our possibility, that was lomustine, integrated with temozolomide in the maintenance treatment of this patient. And in fact, when compared with the use of temozolomide alone, this other arm was better and was much better if patients had an GMT overexpression. So nowadays, many groups, especially in US, are using this maintenance treatment as a standard. If we go inside the aim of this afternoon and precision medicine application also with this tumor, I have shown you that there are many mutations, many pathways, but we have to understand the difference among mutation and drivers. And I've shown you before that there is a small group of patients that have this high-grade glioma containing the BRAF V600E mutation that is more common in low-grade glioma. In this 10% of patients, the mutation is not correlating to a particular prognosis, but this was a good reason to make a phase 2 trial in which also my institution could put the patients for relapsing patients with high-grade glioma and this mutation. At the end of the day, there was a very good response for patients with relapsing high-grade glioma obtained by this administration of dabrafenib that is a anti-BRAF V600 drug, together with the anti-MEC that is trametinib. And the objective response was over 40%, and the publication is this one that was published last year in JCO. At the end, there was over 50% of patients that had a response lasting longer than 22 months. And this is historically the best result in high-grade glioma. But again, this is a very small group of patients with a specific target that was used already, as you know, in melanoma, in low-grade glioma, and in other diseases, changing completely, for what melanoma is concerned, the story of the patients. And as here Smith-Bhatia comments, we do not know how long this response will stay and long-term side effects. What I am showing you now is the real experience in a patient of mine that had a first-line treatment and then a disseminated relapse that is quite common, luckily, in children to have a disseminated progression. And she had, after the use of dabrafenib, 1 year of a complete remission with a very, very good quality of life. And this mutation, BRAF V600E, is rarely found also in the horrible DMG, that are the most ugly tumor in high-grade glioma. And the co-occurrence have been described in some series, maybe with a better prognosis. And we had a patient like this with a very huge tumor that you will see in a while. And she was with a thalamic tumor at diagnosis. This was the reduction of the tumor after surgery. And after 7 months from treatment, again, the tumor was exactly like it was before. She was at admission, comatose, impossible to swallow, and we had the possibility to better study. At the time, it was not a routine examination, this tumor. We found the BRAF V600E mutation, and by introducing trametinib in her garage, she had a wonderful response in just 5 weeks. But again, she progresses after a longer treatment, and despite the addition of trametinib to dabrafenib, she went on with the progressive disease. So there are some experience and some very specific cases where you can use this target therapy. And this is, again, another group of the same tumor. In infantile glioma, there are reports of ALK, MET, TRAC, and ROS-driven tumor, and this group has been defined as infantile hemispheric glioma. Before this discovery, this tumor had a very bad prognosis, but now we know that these tumors are possible to be treated with all those armamentari of drugs that have been used in adults, like lung tumor. And in fact, there were already the first publication with huge tumor and the response in this subset with target therapy. So very suitable for precision medicine. And this is a patient of mine, you see, with a residual disease of a bulbar medullary tumor. And this girl had a particular fusion with ALK and with alectinib, that is a a target treatment for ALK fusion, she initially obtained a response that is lasting after more than 2 years. If we go to fusion of TRAC, this is much more common in other tumors like sarcoma, papillary thyroid tumors, EMT, leukemias, and also a very, very small, you can see less than 1% of high-grade glioma in children. But the responses are really wonderful. This was a presentation of ASCO, and you see that you can follow this patient during time obtaining a complete remission, and therefore no heroic surgery is needed any longer. This is a patient of mine. She was just born with a very big tumor. An operation was tried, and there was a massive bleeding, and the patient was left. But after this, I was asked to see the story, and in fact, she had one of these typical tumor that could be treated in a different way. There are also other new aspects to be treated, to be dealt with, that are the gliomatosis that was erased by the writers and the reviewers, both from the fourth and the fifth WHO classification, because nobody found a specific molecular alteration. And we as physicians, we know that gliomatosis have a different aspect, and the tumor is a multiple nodular tumor in different parts of the brain, but we were not allowed to call this picture gliomatosis again. This paper that was just published was a multinational retrospective study of 104 children that create an internal classification of high-grade glioma with, again, the finding of different tumor within the same picture of gliomatosis. And in these different subtypes, the alteration of EP53 is very important. So we have provided some new tools that maybe will be rescued again in the next classification with very different prognosis according to the more frequent presence of high or low-grade glioma. I will speak a little bit also of what is immuno-oncotherapy. That is the new and very enthusiastic weapon against a tumor. What about the possibility to use it in brain tumor? I will speak just about checkpoint inhibitors and adoptive cell therapy that have some experience to be shown. This is a very common picture that is shown in pediatric meeting, and we compare the number of mutations for cancer that are the target of immunotherapy from what happens with the highly mutated tumor in adults to the most difficult to be treated in childhood that have a very, very low burden of mutation. Well, if all our tumors were in this way, we could not use at all, if not with a specific alteration of this tumor, but this is another story, the immunotherapy. While we have a group of tumor that arise inside a syndrome, that is the germline mismatch repair deficiency syndrome. And in this disease, there is that is a high penetration for cancer syndrome, the glioblastoma or the high-grade glioma, to be more modern with the classification, have the highest mutational burden of all human cancer. Therefore, there are hypothetically a very good field to use checkpoint inhibition. And this that I am showing you now was the first paper showing this kind of response in two brothers with relapsed glioblastoma that obtain clinical and radiological response. At the time of the JCO publication, it lasted 5 and 9 months respectively, but it lasted for a lot of years. I know directly from our colleague in Sick Kids, with a kind of response that is typical of the flare effect that nivolumab does in this kind of tumor. First, this is the flare effect, and thereafter is the remission of the tumor. And if I have to show you a personal experience, not to speak just theoretically, I have these patients. I am waiting for the slide. Okay, this patient that was affected by two high-grade glioma, one in the right and one in the left frontal lobes, and together with this, if this was not enough, she had multiple adenocarcinoma in the bowel. This is a very severe but quite typical presentation in children and adolescents with MMRD. We treated her with nivolumab for 2 years, and we obtained complete remission. I have to add that she had also liver metastasis. This is the last paper published by the consortium around MMRD that explored the outcome of 200 patients enrolled and described during 15 years. This syndrome is very complex common in close communities where endogamy is common, and 19% of the patients developed at least one cancer, and until 18 years, so during childhood and adolescence, this was for not 90% of patients. CNS tumor were the most frequent and had the poorest overall survival rate. Therefore, it's very important to have a good surveillance that this consortium already showed can save a lot of children and adolescents from huge development of tumor. And a little final part of my talk to this modern and very expensive way of giving adoptive cell therapy. This again was the first report almost 8 years ago of the possibility of using CAR T cell in a patient with relapsed glioblastoma. These T cells were given intracavitarily in different part of his brain with a disseminated glioblastoma, and again, when the tumors relapse, it was treated directly into CSF, and all nodules were reduced almost of 100%. And here are the imaging of the different way of adopting this therapy and the outcome of the nodules. And this was used by the San Francisco group of Michel Mongi, also in DMG, and they have a trial ongoing with a response by using anti-GD2 CAR T cell against this tumor, and in a different way, either intracerebral or intraventricular, and these were the first results obtained in 3 or 4 patients, both clinically and radiologically. But if we speak about this kind of treatment, my question going to my first trial, my first slide about the sustainability and the improvement of the treatment remains. How can we think about this as a standard for our patients? So, some last word about the IPG, diffusing principal ganglioma. We now know what is the pathway of alteration that probably is at the origin of this tumor, and we now know also that this is just a part of the whole DMG, diffuse midline glioma group of patients. But some years ago, we were so desperate, and we are still with this patient outcome, that we tried to put our energy together and create a registry, a network. And you see that there are around 300 patients dying for the IPG every year in Europe, around 30 in Italy. And it is like a primary school was bombed each year. And this is not the time that I have to explain what is bombing a primary school. So we did this group of desperate physicians for desperate tumor. At the beginning, we were these blue countries, and then we could enlarge our efforts without any wall and any mountains to be as a border. And the effort is to put the energy together, because the outcome of this patient is still that they have a survival shorter than 1 year, and less than 10% of the patient are alive at 2 years. And what is the standard for diagnosis? It can be also only just the imaging, because MRI is able to distinguish the IPG from other diseases, in particular vascular malformation injuries, and the presence of the diffuse tumor was distinguished from a focal tumor that can be operated. So surgery is not a tool to treat these patients, is a tool to make a diagnosis when the imaging is not typical, but for other indication, so to take part of the tumor, to make analysis and to go on with science, this has to be done in the context of a scientific and ethical supported care, because it is a difficult site and a difficult surgery. Of course, if nobody had made before a biopsy, we still we should be still without any knowledge, but it is not a routine performance for any center. And in fact, the only standard, this is black, I don't know why, but I can explain, the only standard of treatment for this tumor is radiotherapy. Radiotherapy can relieve the symptoms in over 70% of patients, and you can have a very good response, like in this patient, but generally speaking, the freedom from progression is less than 6 months. And a lot of trials have been done to add chemotherapy in this disease, and no standard exists. I don't know if you can see within this part of a paper of some years ago, but if you go here and you can see the 1 year, 2 year, and 3 year, or the PFS, you see values that are around 0 and almost always below 1 year of PFS. So there is something very resistant the blood-brain barrier in this tumor, its impermeability with a different shape of the capillary, and this has been shown also in mouse models, the difficulty or impossibility to go through the blood-brain barrier. And in fact, there are now trials that try to overcome this resistance through different techniques that afford physical experiments like ultrasound technique. This was our experience until 2008. We published this sad paper of not changing anything in 20 years with 4 different trials, and staying with 7 months of PFS and 10 months of overall survival. And this was and is the common experience of most institutions and trials. Thereafter, we could design this different protocol with nimotuzumab, that is an anti-EGFR humanized monoclonal antibody, and you have seen that there is a group of DMG that show an amplification of EGFR, together with vinorelbine and radiation therapy, and we give the systemic treatment both during irradiation and as maintenance, and we give irradiation for relapse. In this way, we obtain a little bit better result with PFS of 8.5 months and overall survival, median overall survival of 16 months. And these experiences were replicated also by other institutions and with other DMG. The possibility of have long-term survival was so real, and in this paper published 6 years ago, Lindsay Hoffman examined those 101 patients that could survive, taking them from the registry that I told you before, longer than 2 years. Of all the prognostic factors that were examined, the fact that there was a use of systemic therapy, especially anti-EGFR, was considered as fundamental. And if we go to see the plan of the long-term survival with their feature, in these 101 patients, there were 11 patients that were treated here with our protocol. So this was a rather better experience than those we had before. Thereafter, I have now to show one of those patients that was surviving now longer than 9 years with a very huge and typical pontine tumor. And this is her MRI now. Is not a normal pons, but is a pons that allows her to be a normal child. And you can see here that she was on television making an advertisement for tortellini, because her parents work in a company that sells tortellini. And this was just for chance that I saw her at the television. So this was our last trial. It was an Italian trial. We were given the same systemic treatment and 2 different ways of administering the so-called standard of treatment for the IPG. One, the standard arm was to give radiation therapy altogether, the 54 grade that are the standard, and the experimental arm instead was to give 3 different, let's say, metachronic treatment with lower dose of radiation therapy. With this protocol, we aim to understand if this different way of delivering radiation therapy could improve our patient prognosis and could enhance the synergistic activity of our systemic drugs. I cannot show now the results of the random because these are not yet ready, but I can show you the aggregated results. We had 55 patients included with a median age of 7 years, and it was not necessary to have a biopsy because, as I told you already, it is enough to have a good and centralized imaging, but nevertheless, it was allowed with different consent by the other center, and 22 of the 23 patients that afforded the biopsy had the typical mutation. 51 relapse. There was an important component of dissemination in those patients, and 51 died. At the end, what we have now are 8.4 months for EFS and 13.9 months for overall survival, and these are the results at 1 and 2 years. To make clear, the use of biopsy gave more dissemination than without a biopsy. So there is something in the procedure that must be taken into account because it may be dangerous for the final outcome of the patient. What we are now dealing with is the possibility to use all our experiences in the first European trial for high-grade glioma. You see here that we will have probably at the end of last year the possibility to include all our patients in a new European trial that will include all these different subgroup of patients, apart those that have a sure target, like those with MMRD or infant hemispheric glioma. In stratum 1, we will include all the MG, in stratum 2, all the other patients, and we will have also stratum for relapsing patients, since, as I told you a lot of time, 90% of our patients still relapse. So the conclusion is that we have a growing body of molecular evidence to describe these patients and possibly not only to develop markers, but you have to have therapies. And it is, I hope not so much, but a little bit confounding to have so many horizontal and vertical possibility to understand and talk with the tumor. So multiple tyrosine kinase, if we speak horizontally of target, or vertically if we speak of downstream pathways. And this is quite well described by this cartoon. But what I hope for my patient and for the career of all younger physicians that work in all the world against this tumor is that we can finally not have a revolution as the one that was a lot of time ago with penicillin against pneumonia, but at least the hope to improve better and better our understanding of genetic, epigenetic, and cellular biology, to have less toxic and more efficacious treatment. In this case, we have not to deal with conventional treatment protocol, but we have to improve the outlook for patients with currently incurable disease. And I thank you for your attention. This is my last slide.
Thank you, Professor Massimino. So we are just a bit longer. So if you agree, we can go with the presentation of Professor Weinberg, and then we are continuing to collect questions, and then at the end of the presentation of Professor Weinberg, we can ask all the questions to both of you. Thanks again, Professor Massimino. Speak to you later for the question. Thank you. So, Professor Weinberg, you can take the control and start with the presentation.
Great, thank you. So I'll now talk about hematologic malignancies, and I'll try to talk a little, I know we're a little bit over time. And I thank you for your attention. So acute lymphoblastic leukemia is one of the most common childhood malignancies. It really comprises almost a quarter of all pediatric cancer diagnosis. So even though when we think about acute leukemia, we think about acute myeloid leukemia and acute lymphoblastic leukemia in the childhood setting, ALL is really our most common acute leukemias. And in pediatrics, we see about 3,000 cases annually. Really, most of those, or 85% of those, are BALL, so that means the blasts express B lineage markers such as CD19. They typically lack CD20. They typically have other immature markers like CD34, and often have CD10. The other small portion of ALL is comprised of T lymphoblastic acute leukemia, or TLL. It's really a smaller percentage, about 15%. A lot of these patients present with mediastinal mass. Sometimes it's a little bit more common in boys, and there's a more variable bone marrow involvement in patients with TLL. So the overall survival in ALL has really dramatically improved. And we'll talk about that in a little bit, but ALL is still one of the leading causes of pediatric cancer. ALL is a lot less common in adults. It unfortunately has a lot worse prognosis in adults, and a lot of that is driven by genetics, as we'll talk about in the next few slides, although the number of cases annually is somewhat similar. The classification of acute leukemias is really increasingly complex and is evolving. So back in 1976, when the French-American-British classification was applied, pathologists would mostly look in their microscope and look at morphology of the blasts, and really spend a long time looking for our rods, which would tell us that it's acute myeloid leukemia. And then if they didn't see blasts, that would be acute lymphoblastic leukemia. And then, of course, flow cytometry evolved, where we could look at what the blasts express and really classify cases based on the markers that the blasts express. But back in 1976, a lot of labs were using cytochemistry or cytochemical stains that we could apply to aspirate smears to really tell us if the blasts had myeloperoxidase stain, and therefore that would be AML. But it became, as our technology evolved to include next generation sequencing and other genetics like cytogenetics and FISH, it became apparent that a lot of acute leukemias had genetics, which were really critical in how we think about acute leukemias. And so that's when the World Health Organization, or WHO classification, evolved. And a lot of that was based on not only morphology and clinical features, but now included immunophenotype. So BALL and TLL were separated, and were separated from acute myeloid leukemia. And sometimes pathologists couldn't really decide whether it was AML or ALL, and they would call that mixed phenotype acute leukemia or acute undifferentiated leukemia if there just wasn't enough markers. And genetics were incorporated in WHO classifications in both 2001 and update in 2008. We'll talk about that in a little bit. There was a 2016/2017 revision of the WHO that really included substantial new genetic knowledge. And really the reason why I focused on BALL is that's the setting where the new genetic knowledge became much more important. And actually, most recently, in the last 2 years, there's been 2 new classifications. There's the 5th edition of the WHO, and in addition, there's the International Consensus Classification, or ICC classification. There was sort of a parallel classification, included a lot of people who were involved in the 4th edition of WHO, and a lot of the changes were similar. between ICC and WHO, but there's also some differences. So back in 1998 or 2000s, the genetic subtypes of BALL between children and adults were recognized that they were different. You can see that adults have a lot more common BCR-ABL translocation, really comprising a quarter of the cases, while a quarter of cases in pediatrics is comprised of having hyperdiploidy or having more than 50 chromosomes. So you basically, acute leukemia gains additional chromosomes, and that's what we think of as hyperdiploidy. And really the other quarter of the cases is translocation between chromosomes 12 and 21 or TD6 rearranged acute leukemias. And then since the 2000 last 2 decades, basically, a lot of efforts have been focused on describing what these random genetic changes are. And that's where really we see a lot of BCR-ABL-like and other genetic changes that we'll talk about in a little bit. So the 4th edition of the WHO really included 13 subtypes of lymphoblastic leukemias. You can see a lot of them on this right side. In addition to the ones that I mentioned, hyperdiploidy and 1221, then BCR-ABL, there's MLL, or what became known as KMT2A rearranged acute leukemia. But the other provisional subtypes of BALL in the 4th edition and now became in the 5th edition NIC is the BCR-ABL, BLL that's BCR-ABL-like, and BLL with IM21 that we'll talk about in a little bit. In 4th edition of the WHO, it was recognized that TLL has that early T-cell precursor lymphoblastic leukemia, which was shown to have a worse outcome, or TP-ALL. And NK lymphoblastic leukemia was a provisional entity, but really that's remained as a provisional entity in the ICC, but is no longer recognized in the WHO. I'm sorry, could you go back? Thank you. So in the 5th edition of the WHO and ICC classification, you can see how some of the changes evolved. So the ICC classification further breaks down hypodiploid BALL into low hypodiploid and the near hypodiploid. And BALL with 922 or BCR-ABL includes both the lymphoid and multilineage involvement. And then importantly, further changes have been made to BCR-ABL-like ALL, where we recognize different classes, ABL1 class rearranged or JAK-STAT activated only in ICC classification. It's a little bit hidden, more other genetic changes in the 5th edition of the WHO. And then the 5th edition of WHO, of course, doesn't recognize provisional entities, so some of that is not recognized. So we talked about this a little bit, but the different subtypes of BLL really differ by age. So in childhood, we have the hyperdiploid, and we have versus in adults, we have a lot more Philadelphia positive like ALL and Philadelphia like ALL. That's the blue and the yellow. And then in the childhood, in addition to hyperdiploid, we of course that have ETD6 RUNX1 translocation and a smaller number of Philadelphia-like cases. And that's of course in the standard risk, which I didn't really go into. But the high-risk childhood ALL does have a little more of other genetic abnormalities. And then the adolescent and the young adults are kind of a mixture of what we see in adults versus what we see in the childhood. I always think it's really interesting to think back of how we got here. And this is, of course, Sidney Farber. He was really a founder of treatments or chemotherapy that's being used in ALL. Back in 1950s, basically, acute leukemia was really fatal, versus today, there's 90 or even 95% survival for a lot of children with acute lymphoblastic leukemia. Obviously, the survival is still unacceptably low for adults. It does depend on age and does depend on genetics. But a lot of the progress that's been made to lead to these really higher survivals is improvement of biology, an understanding of biology of BL, but also improvement in treatment. And that's where Sidney Farber was really key. So you can see how the progression in survival has gotten better throughout the decades. A lot of that was due to initial chemotherapy that was published, but also the next big jump occurred in using CNS-directed therapy. And then further improvements in minimal residual disease have really led us to where we are today. So the goal of risk stratification ALL is really not only to improve outcomes for the patients who are doing poorly, but also we want to treat patients less who maybe don't necessarily need it. We know that a lot of the treatments are very toxic and late effects. If we can minimize the late effects, that's really great. So a lot of that has been captured in presenting features. Older kids and higher white blood cell counts are usually higher risk ALL, but also where the labs come in and pathologists like me come in is really molecular genetic features and describe a lot of how can we detect these molecular genetic features and high risk genetics that would really lead to improvement in outcome. And also assessment of response to therapy. How do we measure minimal residual disease? That we'll talk about in the next few slides. So I already mentioned this was basically the classification in the 4th edition of the WHO. These provisional entities are now final in the 5th edition of WHO and IC classification. So finally we get to a picture of this is what ALL looks like. But despite having very different genetics that we saw in the previous slide, morphologically, all ALL cases will look very similar. The blasts are really kind of small as compared to AML. They have kind of minimal cytoplasm, a little bit of nuclear irregularities, and morphologically, we really can't tell if it's BALL or TALL, so that's where we really need flow cytometry. And we really morphologically can't tell what the genetics are. So a lot of the times when patients get diagnosed, we do have to wait for genetics to come back before we can issue a final diagnosis. So our understanding of BL genetics that are not the sort of big categories include IM21 that we'll talk about in a little bit, but also BLL with deletion in acros or IZKF1, but also BLL with alterations in ERG genes and minimal residual disease. So BLL with intrachromosomal amplification of chromosome 21 or BLL with IM21. It was initially recognized as a distinct cytogenetic subtype of BLL back in 2003. So that was under our 4th edition or 3rd edition of the WHO. But it became a provisional subtype of BLL in the 4th edition of WHO and is now finally a definite category. It's overall fairly low, only 2% of pediatric BLL, but even more rare in adults. But these tend to be more high-risk patients. They tend to be older. They tend to present with lower white blood cell counts, so they're not going to be necessarily captured by that high-risk category, except for the age, of course. The biology, I think, is really interesting. Basically, these cases have multiple copies of RUNX1. All of ALL cases get cytogenetic analysis, and so you can't see that RUNX1 since we're often capturing it by FISH. But usually these copies are on chromosome 21, and it may also be a marker chromosome. And a lot of these abnormal chromosome 21s arise through multiple breakage fusion bridge cycles. And then really interestingly, patients who have germline Robertsonian translocation of 1521 or germline ring chromosome 21, so they report with this, have an increased risk of BL with IM21. So how do we as labs detect this abnormality? And really we can use the same FISH assays that we've always been using to detect ETV6 RUNX1 abnormalities. So IM21 is defined as having 5 or more copies of RUNX1 and one nucleus by interface FISH. Or if we're using metaphase FISH, there's usually 3 or more copies of RUNX1. But as I mentioned, a lot of BLLs have hyperdiploidy or multiple chromosomes, and so you can see a lot of additional copies of chromosome 21 in those cases. But usually it's 3 to 4 copies total. And if you have a karyotype that have additional chromosome 21, duplication of chromosome 21, or derivative of 21, that really kind of sets you up that you may be looking at M21. These patients, when treated with standard therapy, show a high risk of relapse. So we really do need to identify these kids and treat them with additional therapy. And when they're treated with intensified therapy, they really do a lot better. So that's really an example of where genetics, identifying these important genetic changes, have really driven therapy and therefore better outcomes. BCR-ABL-like that we discussed a little bit, Philadelphia-like BALL, is very similar to ALL that has BCR-ABL, but it doesn't have that BCR-ABL1 rearrangement. So these patients have a similar poor outcome. Overall, 15% of childhood BLL has this abnormality, and it really increases with age. So in standard risk ALL patients, only about 10%, but as patients age in adolescence, there's about 20% of patients who will have BCR-ABL-like ALL. And in our young adults, it's about 25% versus in adults, that's where that rate is staying. So if you remember that graph, that's a much higher graph in our adult population. So the biology of BCR-ABL-like BLL is that there's activation of kinase signaling pathways, but what's really challenging is that there's many different alterations. So CRLF2 rearrangements really comprises almost half of all BCR-ABL-like cases. That leads to CRLF2 overexpression. We can actually detect that on flow cytometry, although many labs don't necessarily run that marker. But basically what you get is rearrangement of IgH, which is located on chromosome 14, or on chromosome X, P2, R, Y8. Many of these cases have activating alterations in the JAK-STAT pathways, particularly JAK 2-point mutations. That's where a lot of the research and really efforts have been focused on how do we detect these cases. So the other almost quarter of the cases show ABL1 class rearrangements. And so you have rearrangements of ABL1, ABL2, and these other abnormalities. And you really have very diverse partners. But the common result is that you get that kinase signaling activation. And then lastly, a smaller percentage of cases have activating rearrangements of JAK2. Also very diverse partners. So why is this important? Is because we can use therapeutic targets like tyrosine kinase inhibitors, dasatinib, JAK2 inhibitors in these patients to try to treat these patients. But as I mentioned, there's such a diversity of underlying genetic alterations really makes detection complex. So that's where the labs have really struggled with how do we detect these abnormalities. Children's Oncology Group is using a low density array for screening, and they may be using something different right now, actually. But expression analysis in general can identify this category as a whole, but not necessarily the specific alterations. Some labs have used targeted fusion analysis. You can use multiplex FISH, which is not necessarily available to a lot of labs, or multiplex RT-PCR, or targeted RNA sequencing. But also what could be helpful is a comprehensive analysis like whole genome sequencing, which is obviously expensive, but is becoming less expensive. These patients have inferior survival when treated with standard therapy, just like BLL with M21. But some of the data does show that these cases may do better when treated with the additional targets like dasatinib or imatinib. And then cases with CRLF2 alteration, JAK2-STAT pathway may be targetable with ruxolitinib. We've kind of alluded to ACROS or IKZF1 deletions, which is really important in B-cell development. It was first described as genomic deletions in BLL in 2007, really comprises a significant number of pediatric cases. So that's that other category that I showed initially. So about 15% of pediatric and 30% of adult BLL will have ACROS deletions. Unfortunately, they're not really a distinct genetic subtype, but may occur in other subtypes. And so it's particularly high in BCR-ABL1 cases, that we talked about, or BCR-ABL-like cases that we talked about just recently. So you can see these deletions basically in all types of ALLs. And Nacre's family of zinc finger protein is really crucial for our lymphocyte development. So when we start out as a stem cell, when we develop T or B lymphocyte, that's when Nacre's zinc proteins are playing a role. So they're really important in development. And they also have a wide variety of different gene and subgene deletions that have been reported. So far, it doesn't really seem like the different gene partners have a difference in prognosis, but that seems to vary. And also detecting Nacre's deletions has been very challenging. There's a variety of different breakpoints and different deletion size detections. The commonly used methods include multiplex, ligation-dependent probe amplification, which may not be available, but the copy number arrays or SNP arrays or CGH can be helpful with this. And then the next generation sequencing that a lot of labs are using with copy number analysis can be used in detection of Nacre's deletions. In patients with BALL and Nacre's deletions, there is a higher risk of induction failure and relapse. That seems to be an independent feature in multivariable analysis, so everyone agrees on that, but it occurs in other high-risk BALL cases like BCR-ABL positive and BCR-ABL-like, as I mentioned before, so it may be particularly helpful in identifying high-risk patients, even if it's not a distinct category of its own. And then we talked about hyperdiploid BALL, but hypodiploid, or sort of loss of chromosome markers, is a well-known high-risk subtype of BALL. We can think about it as being in two separate groups. So you can have a low hypodiploid cases, which have anywhere between 32 and 39 chromosomes. A lot of these cases have mutations in TP53 in almost 90% of cases. In pediatric cases, some of these patients will have that germline P53 mutation or the Lee-Fraumeni syndrome. And then there's the near haploid cases, which have even lower number of chromosomes, between 24 and 31. A lot of these cases will have mutations in tyrosine kinase, RAS pathway, and AKCF3. Other newly described genetic subgroups that have made it to recent classification include DEX1 and ERG, but also ZNF3 rearrangement, which is really interesting actually in that it not only occurs in BALL, it also occurs in mixed phenotypic leukemia and very rarely in AML. And then I wanted to spend a few minutes talking about minimal residual disease. That's been a really important measure, which has really led to eradication of leukemia cells and really predicts for better outcome when we can do a really good analysis for minimal residual disease. And it's really become the standard in BALL treatment. And the results of MRD are really used to direct therapy. So labs have really evolved in this, and how do we measure MRD? We know that patients with high MRD can benefit from intensified therapy, and those with lower MRD can be treated with less intensive therapy and still obtain really great results. So morphologically, it's very easy to tell when you have cases with acute leukemia. You typically in ALL see more than 99% blasts versus normal aspirate smears, and this is not a particularly great aspirate smear, but it's what we see in clinic all the time. You can see there's a big difference between basically normal marrow and leukemia marrow. But when, I'm sorry, I clicked on the wrong thing. When we get to after therapy, the detection of morphologic blasts can be very difficult. Some of the immature cells that you think you might be seeing here could actually be hematogones and not abnormal cells. So how do we, so basically we really can't look for minimal residual disease morphologically. So how can we look for minimal residual disease? We need to use other highly sensitive methods. Current protocols require us to detect at least one abnormal cell in 10,000 leukemic cells. We're not going to be able to do that morphologically. It needs to be a very rapid turnaround times in order to be clinically useful, and there needs to be a stable analyte over course of a treatment. So we need to be sure that if there's a leukemic cell, we can detect that. Flow cytometry can be used for MRD. It's very rapid. We're already using it for diagnosis. it usually has adequate sensitivity. The disadvantage is the blasts can evolve, and there could be an antigenic shift. So if you had CD10 that was bright before, it could go away with therapy, and therefore you can't really count on that marker as providing adequate information for you. You can use a quantitative PCR for IgH or TCR rearrangement, but an advantage is, again, it has adequate sensitivity. It's actually very specific for each patient. It's very stable DNA, but the disadvantage is it takes a really long time. Usually it could take a couple of weeks. It's very labor intensive, and with clonal evolution, you can also lose your target. What's become very useful in clinical setting is next generation sequencing, looking for IgH and TCR loci. That's a very sensitive method. It's a universal assay for all patients. You can follow multiple targets. Again, typically, though many labs don't necessarily have this test, they may have to send it out. There is still a turnaround time, and requires a specialized labs to run this test. So, what do we really need to do in, having discussed all these different genetic abnormalities in ALL? What does diagnostic workup really involve? And it typically involves morphology. We need to morphologically look at the slides, look at the aspirate smears, say, yes, this is acute leukemia, and core biopsy. And yes, perhaps we favor it's ALL, but we really need flow cytometry for diagnosis of acute leukemias. And as our understanding of acute leukemias evolved, the different markers we can look for in flow cytometry have also evolved. We can use it is still a standard of care to use karyotype on FISH, even though there's all these other exciting things like next generation sequencing. We still need that karyotype. It helps us to detect hyperdiploid and hypodiploid type of ALL. And FISH really still helps us with detecting BCR-ABL, or that 922 translocation, MLL rearrangement, or KMT2A rearrangement. ETD6-RUNX1 and IM21 can all be detected by FISH. Minimal residual disease can be detected by flow cytometry or genetic analysis, and is really still considered a gold standard in workup and therapy of ALL. And then additional mutational analysis seems to be varying whether we use NGS or we use whole genome sequencing. But we do need to detect high-risk features such as IKZF1 deletion or BCR-ABL1 like ALL. So that's really my last slide, and I appreciate your attention in this very genetically and complex topic. Thank you.
So thank you, Professor Weinberg. So thanks for your presentation. Thanks again to Professor Massimino. So we can start with the Q&A sessions because we have some questions for you. So I start with Professor Massimino. So Professor Massimino, what's your experience with the use of NGS for biomarker analysis in pediatric tumors? It is better to have a large panel of biomarkers specific per disease, and if yes, does the NGS methodology can prevent misdiagnosis in complex or atypical cases?
I am a little shy to answer in front of a pathologist to such a question, but in fact, I married a pathologist many years ago. So I do not guess that you can escape the morphological diagnosis to go to NGS, and you can, after this, say that the pathologist was wrong because NGS showed different things. First of all, you must have a very good pathologic diagnosis. And generally speaking, in pediatric world, especially in neuro-oncology, the first recommendation is to have a centralized diagnosis. And this happens for all our treatment. In Italy, we have a centralized diagnosis since 1994. So this must be the rule, to have a burden of diagnosis in the same place to improve in such rare disease. Thereafter, you can use NGS to clarify experts that are more related to treatment than to diagnosis, in my opinion and in my experience. And this is the same for all solid tumors, not just for brain ones. In general speaking, you have here in my institution, we have a 500 gene platform, but you may use different custom-made platform for different aims. So depends on the question that you have.
Okay, thank you for your answer. So we have a question for Professor Weinberg. How do peripheral blood smears compare to bone marrow biopsies in terms of diagnostic reliability?
I think that's a great question. A lot of acute leukemias will present with a ton of blasts in peripheral blood. And in the setting of ALL, you could do all your additional studies on peripheral blood, which raises the question of why do we really need to do a bone marrow? But in the setting of flow cytometry, you've noticed that there are differences in markers the blasts express in peripheral blood or bone marrow. And so if you're going to then later use bone marrow for tracking for minimal residual disease, you want to have the best immunophenotype that you can detect and not have differences that really weren't there. And obviously it varies. If a patient doesn't have a lot of circulating blasts in peripheral blood, then you do need to do a bone marrow. In the setting of acute myeloid leukemia, where you might have more dysplasia in the bone marrow that you may not be seeing in peripheral blood, then the answer is very simple. You always need a bone marrow. But I think in ALL, you still should do a bone marrow. But unfortunately, sometimes patients get diagnosed on a peripheral blood, and they need that diagnosis in order to be able to obtain their CSF or start their therapy. So we often end up repeating a lot of the studies from peripheral blood and bone marrow. Sometimes you do see differences in NGS studies as well. There might be difference in variant allele frequency. So I guess ideally most patients would have a bone marrow instead of just peripheral blood, but it doesn't always happen in clinical setting.
Okay, thank you. Another question for you, Professor Weinberg. Are there any early detection methods or screening programs for high-risk populations?
Yeah, I mean, I think early, meaning can we detect patients who haven't developed ALL? So patients with, for example, trisomy 21 have a high risk of developing ALL, and so or other germline markers. So can you screen these patients? Yes, I mean, you can obtain CBCs and kind of watch them, but I don't know that we can always detect ALL before it happens. It happens very quickly often. So it's rare, I think, to detect ALL before it really happens, but there are screening programs for high-risk populations. I think they frequently involve just very serial CBCs and just kind of having check-ins, or even having early bone marrows where you may detect dysplasia or other things. Like, for example, patients with GATA2 mutations may get serial bone marrows to sort of allow us to see whether we can diagnose patient before acute leukemias. But I don't know how successful those programs are at really helping us to identify patients before they detect acute leukemia. I think you might be muted.
Sorry, I'm on. Question for Professor Massimino. Do you have any experience or insights about the use of oncolytic viruses as a therapeutic approach in brain pediatric tumors?
Not directly. I know the literature, especially from the group of Professor Alonso. She had a wonderful publication with the interesting experience in New England Journal of Medicine 2 years ago, I guess. And there were some talks also recently in ISPNO in Philadelphia. but I never use this. It's part of this kind of immunotherapy with different approaches. And in my talk, I told that I was going just to speak about inhibitor and the cell therapy, not oncolytic virus, because I have no experience. It's just a literature experience.
Okay, thank you. A question for Professor Weinberg. So we hosted a few weeks ago an event of digital pathology and artificial intelligence. So this is the question for you. How is artificial intelligence being integrated into the diagnostic process of BIOL?
Yeah, that's a great question. I think it's always evolving. I think right now, obviously, it's really only being used in a research setting. I mean, you can think about artificial intelligence perhaps helping us to analyze flow cytometry data, or really predicting what the genetics may be by looking back at a lot of cases and really developing a model for that. We've actually tried to do that with some of our flow cytometry in research setting. I would say it's not really ready yet for prime time, and it really still needs the pathologist integration of arriving at diagnosis. But I think there's a lot of possibilities with using AI in pathology in general. All the manual differentials that we do on the bone marrow aspirate. I mean, I think it would be great if that could be done by AI in the future. A lot of that is going to depend on if we can really store all the slides, if we can really scan all the slides. As of right now, even though we can scan slides, we can't do it at high enough magnifications that we would need for bone marrow aspirate smears. So I would say those are some of the limitations in AI right now in pathology.
Okay, thank you for the answer. This question is for Professor Massimino. It is related to your thoughts or experience regarding the TTF, so the tumor treating fields in pediatric patients.
This is a real tough question, because this kind of treatment has been successful in some publication, but I guess that is not really feasible in children. We discuss a lot about this possibility, but to have this procedure, such invasive and long-lasting procedure, I do not think is feasible in pediatric patients.
Okay. Thank you all. This is the last question. So thanks, Professor Weinberg, Professor Massimino, for your really detailed and interesting presentations, and thanks to the audience. And we covered, but anyway, the topics were really important and interesting. So thanks again, and I hope you have enjoyed and have a good continuation of the day. Thank you all again.
Bye-bye.
Bye.
Bye.